Hi students, welcome to your Advanced Health Assessment Lab. For today's lesson, I will be teaching you how to perform an advanced assessment on the head, eyes, ears, nose, and throat for pediatric patients ages 0 to 4 years old, as there are things that we assess differently when we are working with the youth. You have already been given a demonstration on how to examine the head, eyes, ears, nose, and throat with an adult patient, and I am going to add to your knowledge discussing special considerations for the pediatric population. Now let's jump into it. I'm addressing topics seen straight from your textbook, the Sedale textbook, and we will first begin assessing the head, making sure that the patient's head is at rest. We're going to watch how the patient is controlling their head, how it is positioned, and if there are any abnormal movements noted. If the patient, unless they're a newborn that has poor muscle control, if they're notably head bobbing to a specific side, they're going to need further investigation for a possible cardiac workup for an aortic insufficiency. Also, if the head is notably favoring a tilt to one side, further investigation may be done involving the patient's vision or hearing, as a head tilt can be associated with the patient favoring the side that does not have a hearing or visual deficit. Of note, infants have 7 soft cranial bones, which are divided by 3 different sutures, the sagittal, coronal, and lambdoid. There are membranous spaces between cranial bones called fontanelles that allow for infant brain growth, and sutures start to ossify around 6 years of age when the brain has finished growing. Okay, so what does a head inspection include? This includes looking at the size. Is the head normal size? Is it too large or too small? The shape, is it in proportion to the rest of the body? Is there anything protruding such as lumps or masses? Symmetry, does the head look symmetrical? Lesions, are there any changes to the skin tissue? And then trauma, is there any damage to the head such as cuts, burns, or abrasions? Just of note, when examining a patient's face at rest, slight asymmetry is common. Looking at the head from above can help more accurately determine its shape. It is important to look at a child's growth chart during examination. Measuring the infant's head and comparing it to the growth chart can indicate if the patient's head is abnormally large for their age, and then also opposite if it's abnormally small for their age. Rapid head enlargement and dilated scalp veins can be associated with increased intracranial pressure, and hydrocephalus should be investigated. It is common for infants' heads to be abnormally shaped due to trauma during a vaginal delivery. This can cause edema to the infant's scalp. Caput succedaneum is seen in this image, and that is the most common form of birth trauma, where there is edema in the occiput part of the head, which can make it more difficult to differentiate where the patient's sutures are. And then this can go away within a few days after delivery. We're also just going to look out that the infant is symmetrical, and post-delivery, it's normal for the infant's face to look slightly asymmetrical, but it's important for us to look at the parts of the skull that are asymmetrical and if there's any flattening to the head. Palpating an infant's head involves identifying suture lines and fontanelles. Suture lines should be palpable until around 6 months of age, and there should be 2 fontanelles that are palpated, the anterior and posterior at birth. And if there is a third palpable fontanelle, it's called the mastoid fontanelle, and this is a common finding for infants who are diagnosed with Down syndrome. Fontanelles should not be sunken. This can be an indication for dehydration, and if the fontanelles are found to be bulging, this can indicate increased intracranial pressure. In addition, it is important to know where sutures are located on an infant, because ridges that are found outside these locations can be an indication of a skull fracture. Just of note, sutures can only be palpated until around 6 months of age. Although not commonly practiced, transillumination can be performed if the provider has a suspicion of an abnormally rapid growing head or is questioning intracranial lesions. This is performed when the provider is in a dark room, the light is put against the infant's scalp, and a ring of transillumination should be seen about 2 centimeters beyond the rim. The provider must know when they see any sort of asymmetry or if the illumination is seen beyond 2 centimeters, which can indicate excess fluid or diminished brain tissue. Something to note that is commonly seen in our infants is something called torticollis or wry neck, and this condition occurs when the sternocleidomastoid muscle is contracted in excess, and this can be from birth trauma, but it can also be found later on after birth that would require further evaluation because it can be indicative of an infection, some sort of nerve palsy, tumor, or muscle spasms. Due to time constraint purposes, I am not going to review this slide with you. I thought it was very important to incorporate it in this lecture, but this was taken directly from your textbook, and it is what a typical eye assessment entails. It's on page 230, and you can reference it here or there. As you can see, I can talk for 10 minutes straight about just an eye assessment, so I highly suggest that you continue to review this in your spare time, but we are going to talk about the differentiation between a child and an adult eye assessment. Some special considerations for children's eyes are infants are unable to see close up at birth. Their peripheral vision is fully developed, but it is not until 6 months of age that their vision has developed enough for an infant to see color. And then it is not until 4 years of age that a child can see as of an adult. Observations of the eye. Signs of abnormalities in infants. So if the infant is unable to gaze at the mother or when an object is near them, that is a red flag. If they fail to blink when a light shines in their eye or when an object comes close to their face. And then some signs of abnormalities in children would be if they are excessively rubbing their eyes, getting frequent eye styes, difficulty grabbing and picking up small objects. These are all things that require a further evaluation. Inspecting an infant's eye structure. Is it symmetrical? We're going to inspect the sclera, the conjunctiva, the pupil, and the iris. We're going to see if the cornea is enlarged. If the cornea is enlarged, it's a possible indication of congenital glaucoma. The sclera should be white. Scleral hemorrhages can indicate an increase in intraocular pressures. And then if the sclera is yellow, it could be an indication of hyperbilirubinemia. When shining a light in the patient's eyes, the pupil should be equal, round, reactive to light, and accommodative. This is known as PERLA. It's normal for newborns to have edema to their eyelids from birth trauma. This should resolve by itself. Abnormalities include redness, yellow or green drainage from the eyes, and then also if there's any sort of scleral hemorrhages, they would require further workup because this can be an indication of trauma, such as shaken baby syndrome, a hematological concern, hypertension, or retinal disease. Epicanthal folds or skin folds to the upper eyelid, if they are found and they're unrelated to ethnicity, then this can be a sign of Down syndrome or other possible congenital anomalies. Also, widely spaced eyes can be indicative of an intellectual disability. Strabismus is when one eye turns in a different direction from the other. There is something called pseudostrabismus, which is common in children under 1, and this is commonly associated with a flat nasal bridge. Checking the patient's corneal light reflex is a true indication of strabismus. If it is asymmetric, then it likely is a true strabismus. Continuing on to the ear assessment, this was also taken straight from your textbook, so I am not going to read it, but this is what we do for a typical ear assessment on any sort of patient. I am going to continue on and discuss what we are looking for just in the pediatric population. So for children's ears, infants have short external auditory canals that curve upward. They also have wider and less stiff eustachian tubes, allowing more nasopharyngeal reflux. And then adenoids can block eustachian tubes aeration, which makes it difficult to reach the middle ear, which puts the child more at risk for an effusion of the middle ear. When assessing an infant's ear, we want to use an otoscope, and the position we want to have the child in would be in a supine or prone position to look into the ear. We're going to hold the otoscope with our right hand if we're looking in the right ear in anticipation of moving the tool with the patient as they turn, creating less risk for trauma. The auricle of the ear should be pulled down and back. And then we're going to look at the tympanic membrane. If the child's been crying, it can appear to be red, but it's going to still have mobility if it's due to crying. If there is no mobility and it is accompanied by redness, it may be indicative of an ear infection. Hearing screens. It's important for newborns to have hearing screens performed at birth, as speech and language development occurs significantly up into age 3. And then standing behind the child and holding objects such as a rattle to the left or right of their ear and seeing if they turn towards the sound can be a simple way to determine if the toddler can hear. Same gist here. This was pulled straight from your textbook on page 259. Please review it. When we're inspecting the nose, we're going to look for symmetry and paying attention to the shape and the size of the nose very closely. Flattening of the bridge can be indicative of a congenital anomaly. And then we're going to ensure our patient's nares are patent, as newborns are obligatory nose breathers. So to ensure patency, we are going to inspect the inside of the patient's nares by using our thumb to gently tilt the nose upward and shine a light inside. If there is concern for patency, we might need an ENT consult where they will do a scope and see if they can pass the scope through the nair to see if it is patent. This was pulled from page 259 in your textbook. Please review it on a typical mouth and throat assessment on our patients. When performing a throat inspection, it's very important to utilize the family member that is in the room because the patient is going to be most comfortable with their parent or legal guardian. So we are going to have them help hold the patient. And then if the patient is able to open their mouth and say, ah, a tongue depressor may not be needed. We're going to inspect for dental caries, redness, white spots, swelling, and abscesses. And just of note, retropharyngeal abscesses are life-threatening and they commonly occur in males under 5 years old after an upper respiratory infection. Thank you for listening. Everything that I retrieved is all information from our textbook, Siddell's Guide to Physical Examination, and this was the assessment of a child 0 to 4 years old on the head, ears, eyes, nose, and throat. Thank you.